School of Medicine, and then after her we're going to have Cyndi Chapman, who's with Wesley Medical Center.
Okay, well, hello everybody. Give me just a second to get my bearings. Haha, this is Dr. Kerri Weeks, and hopefully you guys can hear me. This is the first time I've ever done a webinar where I haven't been able to see folks and hear from folks, and no one's been able to see me, so it's a little bit interesting. And I talk with my hands a lot, so that's going to be a little bit of a challenge, but I'm so glad that you guys are with me today. Okay, so I'm figuring out how to use my computer. I was asked to talk about abusive head trauma, and I really wanted to talk, this is really from for the non-medical professional, and I was interested to see that a lot of the folks on were more social work and education oriented, and a few people in the medical field. But I'm really trying to basically get this from someone who doesn't have much of a medical background and give just an overview of abusive head trauma. So we'll go forward with that. And some of the things I wanted to talk about were just reviewing basic anatomy of infants' head and body and why they're susceptible to these injuries, understanding a little bit more about the mechanism of abusive head trauma, or on the slide you'll see AHT. I want to talk about the signs and symptoms of abusive head trauma because many of you will be potentially coming into contact with small children or patients out in the community potentially, and it's important for you to know some of the things that you might want to be looking for, or if want to be more concerned. We will review some of the medical findings and injuries associated with AHT and compare that to some children that have shortfalls and other injuries, and then I wanted to discuss a little bit about outcomes and why this is obviously a concern for us. So that's where we're at. First of all, what's abusive head trauma? I wanted to look at the Venn diagram here at the top, or this little diagram here. It's really a catch-all term. It's an umbrella term that it's a subset of closed head injury, and it can, abusive head trauma encompasses several different mechanisms of injury. The classic mechanism that we think of is infant shaking, and you've probably all heard the term shaken baby syndrome. Infant shaking is really probably the most characteristic and main mechanism by which infants are sustain abusive head trauma, but there's also impact, which is the picture down in the corner here, and I wanted to show this because it kind of it depicts how a child's head might be impacted against something. So if a child is forced down onto a bed, or their head is kind of forced into a wall or a hard surface, that's another mechanism. And then a battered child would be a child that is maybe being hit or kicked or punched, and their head is being injured as part of a more broad physical abuse. Unfortunately, this is one of the leading causes of infant death in the United States, and it's, I think, about 1,500 kids a year, and that's the ones we know of. And despite all of our efforts, unfortunately, we haven't really been able to bring that death toll down over time. It's been fairly consistent. All right, let's see if I can go forward here. There we go. Why are infants so vulnerable to head injury? Well, there's a lot of reasons, but some of the major ones, if you look at a child, they're like little bobbleheads. Their head is larger in proportion to their body, and the musculature and control they have their muscles are underdeveloped, and they don't have the strength and musculature in their neck to really support their head and fight that type of shaking or injury. And their brain is also still developing. They have a higher proportion of water in their brain, and a developing brain is much more susceptible to injury. So those are just a few of the reasons that they are more susceptible. So what's the epidemiology of abusive head trauma? We really don't know the prevalence. What we see is really the tip of the iceberg. Just some of the things that they've done in the past to just try to get a grip on just how common is abusive head trauma. This study was interesting, and there's several studies like this, but I thought this was a good one to illustrate the fact that we are really just seeing the tip of the iceberg. In 2008, Zolotar, who is a researcher in North Carolina, did anonymous phone surveys to mothers of North Carolina that had children 2 years and under. And they just simply asked, have you ever shaken your baby? And approximately 1% of the mothers reported that they'd shaken their infants in the past. And when they compared that number, the number reported in those anonymous surveys, to the actual cases of infant shaking or abusive head trauma that they had identified in their state, the surveys had a report number that was 54 times higher than the actual number that they had on record. So it just shows us that there are, the kids that we see in the medical community that I'm being consulted on are just, they're the tip of the tip of the tip of the iceberg. There's a whole subset of kids that are potentially being injured and not coming to medical attention. It's not necessarily being recognized as such, and we're just seeing the most severe cases. We know several things. We know abusive head trauma is often missed, and I thought this was a very good study. Carol Jenny is kind of one of the forefathers of child abuse pediatrics. She's a pediatrician up in Providence, Rhode Island, and she's been doing a lot of work. She was actually working in Colorado, and she and her colleagues did a retrospective chart review, which means they looked back at charts over the past 5 years at Denver Children's Hospital. And they looked at all documented cases of pediatric head trauma. And what they wanted to do was to see how frequently abusive head trauma had been previously missed by physicians. So, how many times these kids, once they were identified, they looked back to see, well, did they have signs and symptoms prior to when they were actually identified and being recognized? They looked at 173 children less than 3 years of age. I mean, the study is fascinating, but of the children that were normal but maybe had a broken femur or some other concern of abuse, of those children, when they CT. So what does that tell us? That tells us that there are many children with abusive head trauma findings or that have had abusive head trauma that have no symptoms or that could be completely asymptomatic and therefore are likely to be missed. Of the children, when they looked back at the children had seen a clinician, a doctor, for symptoms, signs and symptoms of illness. So we'll go through that. So for example, a child presents and then lo and behold, days, weeks, what have you later, they realize that child had actually been a victim of abusive head trauma. And then looking back, man, they had the signs and symptoms, a couple weeks ago. That way. So it's a real challenge for us as physicians to find these kids, and this is really where, as educators, you're always looking at the family as a whole and trying to figure out what are the risk factors in this family, and these are the specific risk factors for HT, or at least some of them. And they're not. It's not rocket science. It's just I feel like I see this list over and over again. I mean, it's the same things we see for many of the problems that we see with our kids are higher risk. Anything, that high stress, low social support really sums it up. Any families that are in a high stress situation due to finances, due to loss of support, are really at higher risk. This includes young moms, those young single moms that have an unrelated male caregiver in the home, so young moms with maybe a young boyfriend who isn't used to caring for infants, certainly at higher risk, parental depression, domestic violence, substance abuse, and then prior abuse in the family. All, again, not surprising. Some of the characteristics of the perpetrators, actually, when they look at those, when they look at anonymous surveys of men and women, have you ever shaken your baby, that kind of thing, men and women actually self-report shaking at the same rate. So, when you look at those surveys, men and women are kind of equal as far as perpetrators. But when you look at kids that are hospitalized and seriously injured, there's a slight predominance of male perpetrators. And I honestly don't know why that is. I guess we could surmise that that's because men are stronger or you know, have more of a violent streak or what have you. I mean, that would be my guess, is that potentially they have the strength to inflict worsening injury. As far as child characteristics, there's a slight male predominance. The peak age that we see with these cases is 2 to 6 months, although I have seen my fair share of toddlers with these injuries. 2 to 6 months is really a key time frame because that is the peak age of infant crying. And many of you have probably heard this before, and certainly there is a statewide, community and statewide campaign on letting parents know about normal infant crying. You've heard of the period of purple crying. Really wanting to educate parents that this is a normal developmental milestone and, you know, help them deal with infant crying so that it doesn't come to this. But infant crying is often cited when perpetrators do give confessions and talk openly about what happened. They often cite crying as the thing that really pushes them over the edge. With a little bit older children, potty training tends to be a big issue, and fights over what they eat and don't eat at dinner time is also another. You know, the things that the parents battle, you know, when their kids are little, often cited. So, multiple gestations are a risk factor. So if you have, you know, twins, that puts them at higher risk. Again, I don't know exactly why, except just to say that it's an increased stress. You know, when you've got 2 babies to take care of, or 3 babies versus 1, that's an increased stress on the parents. Prematurity is a risk factor, and also colic and fussiness. Certainly if you have a fussy, colicky baby, you know, that's just going to make it more difficult to care for that infant, and they may cry more. It is interesting. I see a lot of babies that are diagnosed with colic, or what we call reflux, which is basically baby heartburn, where they're spitty and they cry a lot and they just are difficult to feed. I see a lot of the infants I see that have had abusive head trauma have been diagnosed with that colic and spittiness in the past. And I wonder which came first, because certainly that colic and spittiness can be a result of abuse as well. So I'm not sure. You know, I think there's probably a mixed bag there, that sometimes the symptoms that the parent is really struggling with are from previous abuse. Okay, so this brings us to kind of what I was just talking about, clinical signs and symptoms of abusive head trauma. So these are the kind of things that you may hear or see out in the community, and just to keep your ears and eyes open as you're looking at kids and interacting with families. Again, so many of these can be are just right in there with normal childhood stuff and normal childhood illness. So none of these are really specific for abusive head trauma, but certainly could be an indicator. So probably the least specific things are things like inconsolability, irritability, extreme fussiness. And I always tell parents, you know, we go through the period of purple crying and talk about normal infant crying, but I always encourage them, if you're uncomfortable, if, you know, seek medical attention or support if you feel like this has gotten to an excessive point, or you're not sure what to do, or you're worried about your baby. Not feeding right, loss of appetite. With infants, feeding is a pretty big indicator on how the child is doing. If they are not feeding well, that's really one of the first things to go when they're ill or have been injured. So feeding is a big indicator. A lot of times babies will be spitty or have excessive vomiting. And then it kind of progresses from there. Those milder symptoms, the more irritability, poor feeding, are more general. But then they can progress to trouble breathing, or kind of funny, shallow breathing or odd breathing patterns, to seizing, to being really stiff, to their bodies going really limp, so changes in the baby's tone or posture, and the baby not being responsive or excessive sleepiness where they can't be woken up. So some of those more extreme things, certainly those are the things that tend to prompt medical attention, where EMS is called or someone says, you know, this baby isn't looking right, we need to take him to the doctor. Those more extreme signs into the spectrum there. Okay, so I wanted to talk a little bit about the actual injury itself and associated injuries and give you guys a little bit of idea of what actually is going on in the brain. I really don't have a lot of graphic images or anything like that, so don't worry. I don't like to traumatize people, but I wanted to give you a little bit of an idea of what we see and why, how we diagnose this and what makes us concerned. So this is where I usually talk with my hands, so bear with me. But I do think I have some pretty good visuals here. So yeah, I guess I can use, you know, yeah, Cindy's saying go ahead and use your hands. So no big deal. So look at the picture that you have on your screen there, and you guys can probably all picture kind of that classic mechanism of infant shaking where the perpetrator has their hands wrapped around the infant's chest, kind of pads their fingers along the baby's spine, and what a shaking would theoretically look like. That's depicted there. So during that event of shaking, so a child's brain and our brains are suspended in our skulls. They're kind of floating in our skulls. And they are tethered to the skull by blood vessels. And I think I have that on the next slide. So if you picture, you know, I think one probably reasonable thing to picture, since it's Easter time, would be an egg. So if you picture, you know, the outer shell of an egg as the skull and then the yolk of the egg as your brain, it's kind of floating in there in the gelatinous white stuff, and it's, you know, kind of attached but still just kind of suspended in there. So a very similar type of picture. Imagine what happens during a shaking. The brain is kind of bouncing around in the skull and it is injured, and the blood vessels that tether the brain to the skull are stretched, and the cells of the brain are damaged, and damaged cells swell, not getting oxygen to the brain, and everyone knows obviously that's very key for cell function, and have torn. So there's a lot of different things going on at once, but it's very damaging to the brain itself, and it doesn't, after a severe shaking event, it's very difficult for oxygen and nutrients to get to those cells and for the brain to function appropriately. Oftentimes after a serious shaking event, the child is immediately, well, the child is immediately not the same. They're immediately symptomatic, and we see the tip of the iceberg cases that we see in the hospital. Very many times the history is that the child goes immediately unconscious or immediately unresponsive. So those more severe cases, the child is immediately severely impaired. The associated injuries we're going to talk about today are specifically retinal hemorrhages, and that's bleeding in the back of the eyes, rib fractures, and a special type of fracture called a metaphyseal fracture, which is another type of fracture that is specifically associated with head trauma. So we'll walk through. I wanted to start, again, this is the subdural hemorrhage. So this is what I was talking about when I was talking about how the brain is suspended in the skull by blood vessels. And let's see here. Okay, so if you can follow me, this looks very medical, but if you can hang in there with me. Here's your brain. If you can picture, you know, you've got kind of those gyri, and here's the skull here. Now there's layers of tissue and blood vessels between the skull and brain, just as there's, you know, your layers of fat and tissue and scalp above are these blood vessels, and they tether the brain to the skull. So if you can imagine during a shaking, the skull's subdural space, sometimes it accumulates in other spaces, but that's the main space where blood tends to accumulate, and it's a very specific place where blood accumulates specifically after a shaking type event. We just don't see it in other forms of trauma. It's pretty specific to this shaking type mechanism because of how the injury occurs itself. Okay, sometimes we see them in the other types of things that we would see a subdural hemorrhage accumulate would be, other types of trauma would be something like a car crash or a high-speed motor vehicle accident where a child was ejected from the car, something where there's a lot of force and the baby's head is moving in a whiplash motion, not something like a fall off a bunk bed, very high force on a CT scan. This is a coronal view, so you're actually looking down on the top of someone's head. So if someone sliced the top of your head off and looked down on it, this would be what they would see. These black jelly beans in the middle are the ventricles for some of the fluid around the brain is created and accumulates, and you can kind of see the brain in there. The white ring around the outside is the skull, and then you can see where the arrows are pointing, kind of that dark gray, moon-shaped, that blood collecting between the brain and the skull. So what are some of the associated together? Not always, but they tend to go together, and so when we see one of them, we look for all, if that makes sense. So retinal hemorrhages, I wanted to kind of give you a view of normal and then abnormal, and I think sometimes a picture says 1,000 words. But your retina is a multi-layered, retina is multi-layered, and it's along the back of your eyeball. And there's blood vessels that teem through your retina, which is layered like the layers of a cake. And it's where the light reflects and sends images to your brain for vision. Okay, so here's a normal human retina. So when your eye doctor looks in the back of your eye, this is what they're seeing. And you can see the optic nerve there that transmits images to the back of your brain and all the blood vessels teeming out of that. So with a shaking type mechanism, the blood vessels that are teeming through those cake layers of the retina are sheared and torn, very much like the blood vessels that create a subdural hemorrhage in the brain. They're stretched and torn and kind of pulled and pushed every which way, and they cause hemorrhages to occur in different layers of that cake or that retina in the back. And so oftentimes when I look in the back of an infant's eye at the ophthalmologists come up, because they have special cameras. Obviously they can see things in much more detail, and they're much better at just the very, very back portion of the eye. Their camera allows them to reflex and look all the way to the edge of the eyeball. And it's very cool. They can get a much broader picture of the back of the eye, and they can actually tell which layers of the retina those hemorrhages are in. And the reason that's important is because really the pattern of retinal hemorrhages that we see in abusive head trauma is usually there are numerous hemorrhages, and they're very diffuse, and they extend clear out to the very edges of the eyeball, and they're through multiple layers. So we really want to get a full view of that. Okay. Interestingly, I guess I could go back one. Let's see if I can do that. I don't know if I can. There we go. One comment on this. Most of the time, and usually the child can have normal vision. And they take maybe, I don't know, 6 weeks, 2 months to heal, something along the lines of, weeks to heal, but they don't affect vision like you would think. The reason we do see a significant amount of kids that have vision loss after, so it's actually due to brain damage, not eye damage, if that makes sense, that a lot of these kids have vision issues. Okay. The second injury I wanted to specifically talk about is rib fractures. Predominantly, this occurs in infants or children less than 2, which is most of the infant abusive head trauma we see, or abusive head trauma we see, is in kids under 2. It's a very common fracture in abuse, and we just rarely see it outside of abuse, and it's really associated with head trauma for the following reason. So you can all picture and see the spine, and this is a good visual as well. So here's the sternum, and the thumbs are here, and then here's the spine, and the fingers are just aligned right up with the back of the spine. So This is a good view down here of what happens when that chest is compressed. When that perpetrator whose hands are wrapped around here squeezes during a shaking event, the ribs are bent right over that spinous process, and that is typically where we see the fractures. Now we see sometimes we see them out there on the side or in the back, but those posterior, oh geez, I'm horrible today, posterior, those posterior fractures are really the most common because just because of the mechanism and that bending, and these are difficult to see on x-rays. Typically when the kids come in, we get a full skeletal survey right when they come in, and it's an x-ray of, it's 2 views of every bone in their body, and we get multiple views of the ribs, really looking for, sometimes we don't see them, and I'll usually recommend that we have a repeat skeletal survey in a couple of weeks because they're much easier to see when the bones start to heal. When bones start to heal, they build kind of a scaffolding or a callus around the point of the break, and it shows up really well on x-ray. It shows up like looks like a coin. In fact, let me go back, and I think you can see them pretty good on there. See how these little balls on the ribs there, those are healing rib fractures, and they show up really well. So a lot of times we'll do 2 sets of x-rays, and that gives us a better feel for those. Okay. The last type of injury I really wanted to point out, they're called metaphyseal or corner fractures. And I've got one point, I think there's several on this set of x-rays in front of you, but I pointed out probably the most obvious one. And it's really very subtle on x-ray. They're difficult to date, but they're very highly specific for abuse. We don't see them in accidental injury. And it's essentially a chip off the end of the long bones. So commonly it'll be a tibia, a femur, which is the largest bone in your thigh, or your chip off a tibia, which would be the big bone in your lower leg. Sometimes we see them in humerus, which is your upper arm bone. But they are caused from a pulling and twisting motion of the limb. And so this could be, during an aggressive diaper change where, say, or the child is not wanting to hold still, and the perpetrator pulls and twists their leg in an attempt to get them, and they're kind of going through this pull and twist motion as they flail about, and that causes this type of fracture. Other physical findings that we look for, and these aren't necessarily things you would particularly be assessing for, but just so you know, an enlarging head, facial or head trauma, and these things are things you might see. And even if they're subtle, I like this picture because the bruises on this child's cheek are fairly subtle. They shouldn't be there. And, an isolated bruise that it's clearly explained is one thing, but if you see numerous bruises on the ears, that shouldn't be there. Frenulum tears are another common thing. I feel like I see these all the time. And in mobile infants or mobile kids, they're not as specific. I mean, we've all probably seen a kid that's fallen against the coffee table and torn their lip, something like that. But in non-mobile infants, they're very concerning for abuse, and they're usually from somebody shoving a bottle or shoving a pacifier in the child's mouth. And then looking for other signs of neglect. I always want to make sure the child has had good medical care, they're being well cared for. Are they dirty? Do they have a bad diaper rash that's untreated? Do they have dirt under their nails? Their nails haven't been trimmed. And looking at their weight and looking for signs of just malnourishment. Those are all things that are really important when you're looking overall at the picture of is this child being abused or neglected. So when you're out doing your calls, be looking for this kind of stuff. Unaddressed medical needs, malnutrition, poor hygiene. I think I'm down to the last couple slides. I wanted to talk about the histories that we often get with abusive head trauma. Most of the time, the history is either not provided, so there's history of no trauma, or it's of some minor trauma. Some of the kind of classics, we have kind of I guess a gallows humor joke about the killer couch. The child fell off the couch. That's kind of a classic. The child rolled off the couch, and now they're in the ICU with all these horrific injuries. And that just doesn't match up. I mean, that doesn't take a neuroscientist to say that. It just doesn't sound right, and it's right. I mean, we don't see that from shortfalls. So some sort of a shortfall. The other one is a sibling, like a toddler sibling, fell onto the child or hit the child with a toy, or that a pet fell on the child or jumped on the child or something like that. So a lot of times these are attributed to kind of normal roughhousing type things. So just be aware that, I mean, the type of injuries that we're looking at take a lot of force and a very specific mechanism. And this just shows you with vertical falls. So short vertical fall would be roll off the changing table, roll off the bunk bed, fell off the kitchen counter, something like that. And less than, we do sometimes see skull fractures with those type of short falls. Less than 5% of those short falls will end up in a skull fracture. And, if in that case, they're usually very simple linear skull fractures, and the child is neurologically fine. They don't amount up to significant neurological injury most of the time. And the most recent, they did kind of a meta-analysis of the literature, and it's been probably a couple of years now, but when they looked at all the literature, you have less than a 1 in a million chance of dying from a short fall. So it's very unusual to have a serious injury from a short fall. So if that's the history and you're seeing a child in the ICU or a child that's clearly needs to be taken in by EMS, it should raise your red flags. So last 2 slides, I just want to talk briefly about the outcomes. When we look at all comers with head trauma, the children that have had abusive head trauma have a much higher mortality, longer hospital stays, and worse morbidity than kids of accidental head trauma. Even kids with pretty severe accidents, kids that are in car accidents and fall from 2-story buildings and things that you would think of as pretty severe, those kids do better overall than our abusive head trauma kids. So it is very, they have significant morbidity. They have a higher incidence of long-term effects like cognitive delays, motor delays, feeding problems, vision and hearing problems, seizures, that kind of thing. I often get asked, what's this kid's prognosis? What's their functioning going to be like? And, the bottom line is every kid is different, and it's a wait and see kind of thing. But, I've seen a lot of kids that I really thought were not going to do well, and they leave the hospital and they don't need a G-tube, they're off oxygen, they're developmentally coming along, and they probably have a fairly reasonable prognosis. But even the kids that are doing well as infants and toddlers, we have to watch them so closely because we know that most of these kids are going to have problems when they get older, maybe not even recognized till school age. A lot of the kids end up with the diagnosis of ADHD, they have behavioral or cognitive problems. So even if they kind of, seemingly as an infant, they kind of, they're the lucky one that is doing okay when they leave the hospital or appears to be on track, the chances of them having some problems as they get older is very high. And so we do screen these kids and keep a very close follow-up on them. And then on the opposite side of the spectrum, unfortunately we see kids that are just very devastated and really don't have much function. But most of these kids need a lot of subspecialty follow-up. So this is just a list of my resources. Should I pass it on to you, Cyndi? Anything else? Did you guys get any questions or specific stuff for me? No questions. I'm good. I'm just kidding. Okay, so I'm going to pass it over to Cyndi, and you guys might have to change your PowerPoint. Thank you.
Well, thank you, Dr. Weeks. And as we pull up Cyndi Chapman's, there we go. And if you do have questions.
Hi, this is Cyndi Chapman, and I'm from Wesley Medical Center a lot, and there's just a lot of things that I just kind of wanted to share with you guys. I know that you are all kind of aware of things that go on, but just kind of wanted to give you a little bit of a background of what goes on after or when we get these patients in the hospital, and how we kind of look to each other to work it out, and how we want to make sure that we all collaborate and do the things that we need to. I think the biggest thing that we all know that we're all mandatory reporters, and I think everybody that had clicked in here were pretty much in your career. You're definitely a mandated reporter. So patients, or you hear that a child comes into the to make sure that we get what's best for the patient and the child. You know, we tend to think that we're very suspicious. We look for things that we probably think that we're always looking for the negative, but that's not really what our goal is. Our goal is really to keep the child safe, and that's what is the most important thing to all of us. And I think that you have to put your own things aside to not feel like you're going to be in trouble, or you're going to have any of those things that might go on because you like the mom or you like the dad. And you know, we all understand that. We've all been in that situation. However, you know, keeping our eye on the ball for the kid is really the thing that we're doing for the advocacy for that child. If we can save one child, it's worth 1,000 kids. So it really is important that we all kind of come together for that. I think you all know how to report. The reporting, there's a state and a national line that you can report to, as well as 911. 911 is always a go-to thing, that if you have any suspicion with anybody that you think needs to be looked into, and you know, some of you guys are already working for DCF, maybe not, maybe you are, but 911 is really the quickest way to get to any child to be looked into their situation. If you feel like that you need to do that for any child that you see. You're protected through lawsuits. That's not a thing. Mandatory reporters do not get put on the stand because you reported. It's always anonymous, and you can make it as anonymous as you want it to be. And so we want to make sure that you know that the biggest things you want to do is report the part that where the child is and and you know, they'll ask you maybe your name too, but that's never going to get anywhere that anybody else gets to see. And you don't have to give your name. That's important too for you to know. And I think it's really important that you make sure that you keep the eye on the child. That's the 911 is the immediate response. They're open 24/7, and it's anonymous to them. And then you also know that there's the 800 number for DCF, and they are open. They take those calls 24/7 too, and it's also an anonymous report. So I think it's really important that we all keep our eye on the ball for that. One of the things that I was going to try to also share with you is that once these kids come into the hospital, we do an extensive amount, like Dr. Weeks had talked to you guys about what we look for, the tests that we do. We take a lot of calls from you guys. We would love to hear from you to do an in collaborative report for these kids so that you know what's going on as well as we know what you're concerned about. We have a care team, which is the child at risk evaluation team that we have that can be called through any of the hospitals here in town in Wichita. And I don't know if you're all around this area, but I think you're all across the state. So in Wichita, if you ever have any questions, if you're outside of the Sedgwick County area, you can always call via Christy. You can always call Wesley and ask the operator to get you in contact with the care team. And that's how you would ask for it. It's the Child at Risk evaluation team, so it's CARE team, and so you would ask for the care team, and they would put you in contact with Dr. Weeks or Dr. Melhorn or Dr. Heflin, whoever was on call. They know that call schedule, and they would get you right there. We really encourage you to use them in terms of if you have a question, if you think you've seen something, if you're not sure you want to report it and you just want to go on, it's really important that you just go ahead and call, and they will call you back and talk to you about what your situation is and what it is that you might want to do. When we do have children in the hospital that we put in the care team, we have a team set up of the child at risk evaluation doctor, the nurses in the units that the patients are in. We have the district attorney, we have the child advocacy center, and the police department, and then we also work with your district attorneys within your own counties to work with what we can. The police department here in Wichita are willing to help out as they need to. We all talk together as what we need to do. If it's a patient that comes from a different county than Sedgwick, we all work together to make sure that we get this child safe and what we have to do. So we talk through the situations, we work on what we need to do and where we're at. So, you know, as Dr. Weeks had kind of told you, there's different patients that we've had come into the hospital that come in for very mild things that we eventually do some major test or minor tests, honestly, to just look at it. And some of that can be the skeletal surveys that Dr. Weeks had kind of talked about in terms of looking for old fractures or looking for anything like that. If we have children that come in sometimes with reflux that can't be determined what's going on, she told you about the minor incidences that turn into some abusive head traumas that we've seen, because those can be the secondary or the primary reason that the patient might have been abused in whatever it might be besides the crying. Maybe they throw up a lot, they get somebody else's clothes dirty or whatever. So it's just really the nature of what we look at every day and what we want to make sure that we keep these patients healthy. We tend to always want to make sure that we do a collaborative effort and make sure that you understand what it is that we need from you and what we need from you and what we want to do for you to work together with you. So we may be asking you questions that don't sound exactly the same, but we do want to make sure that we're doing everything that we can do for the patient, or for the child, actually. It's not always a patient, it's always a child in your life. So this is Dr. Bruce Perry's thing that he's always said about kids. I don't know if any of you have been able to hear Dr. Bruce Perry or Dr. Rick Gaskell, but they definitely do a lot with our child abuse children in the community. And if, like I said, if we can save one, it's worth it. And we really need to keep the eye on the ball to make sure that the community knows that we have to look out for our kids. And you know, in the United States, the 20 million abused, neglected, and traumatized children are vulnerable to these children. Our society has yet to recognize the epidemic, let alone develop an immunization strategy. So I think it's really important that we all work together, and whatever we can do to help you guys and whatever we can do to get you in touch with the Child at Risk Evaluation team, or if you have questions, we're always open 24/7 in the hospitals to help that, no matter who you're aligned with to call. We're here about keeping children safe and not having them have the abused head trauma. So I think that's all I have at this point, but we would love to have some questions. We really want to have some dialogue. Dr. Weeks would love to answer any questions that you have.
Of course I would. No.
And whatever we can do to help you guys get through anything that might be interesting to you, and what we can share. Maybe one question might spur on some other ideas that you guys might have. We have one? Can we see it? Dr. Melhorn made a comment.
Yeah, I'm blind. Hold on, let me just get the computer over here.
Dr. Kathy Melhorn has made a comment for us here.
You want to read it? Oh, I can see it.
Start here. Reporters here. It's important for participants to understand that reports can be made anonymously, but investigators can act on the information more appropriately if they know who the reporter is. Reporters' names are not disclosed, but parents can sometimes figure out who made the report based on the information given. It is always best for the mandated reporters to, we're going down, Dr. Melhorn, hang on. It's always best, where do we go here? Okay. It's always best for mandated reporters to identify themselves in order to strengthen the response.
Yeah, I completely agree. I think I'd never hesitate to give my name and just make a comment that to have the caseworker call me, or whoever gets assigned call me, so I can provide more information. You know, if you give the DCF report, you know that you're giving the report to an operator. It's not actually the person that's going to be doing the investigation. So they're taking kind of minimal information to get things rolling. But oftentimes, you know, I feel like I have a lot more to convey to the caseworker than what I can actually even say on, you know, my initial report. So don't hesitate to give your name. Any other comments or questions?
I'll give you a minute or two just to if you're still typing, but just as some kind of housekeeping FYI, are going to kick off the Click for Babies campaign. This webinar is on May 22nd, which will just give some general information about Click for Babies and how it is that it does support the period of purple crying. We also, some of the information that you would see here today, as well as if you've sub under KCSL 100, you'll find that there.
Dr. Melhorn as well, who's watching or listening to the webinar, I guess. We're both very available, and if you're in an outlying area, I really made it a goal, and I would love to know who you are, if you're a provider out in that area, or if you ever have questions. We just want you to know that we're very approachable, and if you page us through the operator, through the Wesley or Via Christi operator, there's always someone on call. We don't mind curbside consults if you're in an outlying area. We just might be able to give you some guidance. So just don't hesitate to get a hold of us if you need us. In these cases, there's no two alike. I mean, I feel like every day is a different day at work, right? I'm sure you can all relate. So sometimes it's just nice to bounce something off of someone else. So just don't hesitate to call us. And in that regard, if there's something about, if you think of a question later, or there was something in my presentation that was unclear, or well, what was that again? Don't hesitate to call and ask me about it, and I'd be happy to send out. I think we just discussed making our PowerPoints available to you guys somehow, so that you could use, if you like the graphic or something on there that you wanted to specifically remember, you would have access to that. So we'll make sure we get that to you as well. So.
A survey for this, and we'll also put in there if you would like a copy of the PowerPoint, and if you need a certificate of attendance, you can just send that email back to me and I'll send those out to you. And so again, we just want to thank everybody for coming, and thank you again to Dr. Weeks and Cyndi Chapman.